my distinct pleasure to introduce Elena and Kylie. They will be presenting their research on the effectiveness of a occupational therapy intervention for fatigue in individuals with traumatic brain injuries. This project was especially difficult because they were doing a secondary data analysis of a randomized clinical trial that was completed a few years back. And secondary data analyses are always more difficult to do because you have not had direct access um, to the participants, as well as you've not had a chance to collect the data. However, they both, as you'll see from their presentation, have done a wonderful job, even with a difficult secondary data analysis. And I would like to go ahead and present Elena and Kylie.
Thank you, Dr. Reyna, for that wonderful introduction. My name is Elena Friedrich.
And my name is Kylie Asmus. And today we will be presenting to you our research project titled Assessing the Effectiveness of the Max Intervention in Reducing the Impact and Severity of Fatigue in Individuals with Traumatic Brain Injuries. To begin, I will first be discussing what a traumatic brain injury is. As defined by the Center for Disease Control, a traumatic brain injury, or a TBI, is defined as a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head, or a penetrating head injury. The altered brain function sustained from the injury is classified by a loss of consciousness, retrograde or post-traumatic amnesia, altered mental status, or neurological deficits. An individual who has sustained a TBI can experience temporary or permanent physical, cognitive, or behavioral impairments. Cognitive impairments may include deficits in memory, attention, executive function, processing speed, and communication. Common behavioral deficits an individual may experience include agitation, impulsivity, confusion, aggression, and social inappropriateness. Lastly, they may also experience physical impairments such as impairments with coordination, changes in muscle tone, or paralysis. The severity of the TBI is related to the extent of the injuries and symptoms experienced by the individual. The Glasgow Coma Scale is commonly used to determine severity. The scale measures the level of consciousness in coma following the brain injury. A score of 13 to 15 indicates mild severity, a score of 9 to 12 indicates moderate severity, and then a score of 8 indicates severe TBI. According to the CDC, it can be estimated that there are around 3.2 to 5.3 million individuals living with a TBI-related disability in the United States. It is also projected that 1.5 million Americans will sustain a TBI each year. Since 2007, there has been a 45% total increase in traumatic brain injuries. With an increase in the traumatic brain injuries over the years, hospitalizations have remained stable and deaths have decreased, which may indicate the increased total may be due to an increase in emergency room department admissions. These statistics show there is an increased number of individuals living with a TBI in the community. Due to the increase in people living with a traumatic brain injury, there is more of a need to help manage deficits that accompany a TBI. Although an individual may experience permanent or temporary impairments with neuromuscular, cognitive, emotional, or behavioral functioning, fatigue is a common symptom that occurs after a TBI. Fatigue, which is a disabling symptom, affects around 45 to 73% of individuals. Post-TBI fatigue is different from typical fatigue that people experience in their everyday life. Post-TBI fatigue can be a combination of mental, physical, and psychological fatigue. An individual may experience difficulty with starting and continuing activities. One of the main differences with post-TBI fatigue and everyday fatigue is that sleep does not help reduce it. Research has shown that fatigue is chronic and can decrease within the first year, but may continue to persist for many years. A study done by Ouellette and Morin examined the frequency and characteristics of fatigue after a TBI. There were 452 individuals that sustained a mild, moderate, or severe TBI. The results showed that 94.9% of individuals reported experiencing more fatigue after the injury than before. When examining the level of fatigue throughout the day, the individuals reported to have lower levels of fatigue in the morning, but increases throughout the day, with nighttime being the worst.
Continuing on with the introduction, I will be talking about the effects fatigue has on individuals with a TBI, along with energy conservation strategies and work simplification. Fatigue can have a large impact on individuals' quality of life and well-being. While fatigue in those with a TBI is reported to be challenging and distressing, it also interferes with their ability to work, socialize with family and friends, and lead a normal life. Fatigue has also been shown to impact social and physical functioning, leading to poorer quality of life, general functioning, cognition, and well-being. Zveen and colleagues conducted a focus group for individuals who sustained a mild traumatic brain injury, and it focused on their TBI and brain functioning, physical activity, cognitive deficits, and working daily activities. The results from the groups found that fatigue was the most pervasive symptom that affected their occupational balance, participation in work, and resting time. Other common issues that were stated in the group were having to spend more time planning and managing daily activities, along with interpersonal relationships. While there is not much research on energy conservation strategies and work simplification to reduce fatigue in individuals with a TBI, there are studies that show its effectiveness with other chronic conditions such as breast cancer and multiple sclerosis. The Multiple Sclerosis Council for Clinical Practice Guidelines define energy conservation education as identifying and modifying activities to reduce fatigue in occupations such as work, home, and leisure. Individuals with multiple sclerosis participated in a 6-week, 2-hour energy conservation course that focused on fatigue that included lectures, goal setting, homework, and practice activities. It also focused on the importance of rest, positive communication, environmental modifications, and activity analyses. The group that received this treatment showed significant decreases in physical and social fatigue impact scale scores. A study by Reina et al., which this secondary analysis is based off, looked at the feasibility of using an 8-week maximizing energy intervention utilizing the problem-solving therapy to educate those with a traumatic brain injury on how to manage their fatigue. Energy conservation strategies such as monitoring energy expenditure, reducing the task into smaller steps, incorporating rest, teaching proper body mechanics, pacing their routine, and utilizing resources and equipment can be used to help clients learn to adapt their daily activities. The PST is a framework that uses 7 steps to teach clients how to identify problems, set a goal, identify and implement solutions, and evaluate solutions and outcomes. The PST can be used to help individuals learn energy conservation strategies, and it incorporates a behavioral approach for problem identification and solving, including educational materials, and using the skills learned to generalize them to other problems that are related to fatigue. While this intervention is shown to be feasible, the effectiveness of the max intervention on reducing the severity and impact of fatigue is unclear. The purpose of this study is to determine the effectiveness of the max intervention in reducing the severity and impact of fatigue in individuals with a traumatic brain injury.
Now I will be discussing the methods of the study. The study was a pre-test, post-test design. This study is a secondary data analysis of a parent randomized control trial examining the feasibility of the MAX intervention conducted by Reina and colleagues. We examined data related to the Modified Fatigue Impact Scale and the Fatigue Severity Scale. All participants in the study were from the previously mentioned randomized control trial. The participants were only from the MAX intervention group, and they were recruited from the University of Pittsburgh Medical Center, local TBI support groups, and the TBI Research Registry. The inclusion criteria from the study includes adults with a history of mild to severe TBI, at least 6 months post-injury, a score of 4 or more on the fatigue severity scale, indicating limitations in activity of daily living due to fatigue, live within 50 miles of the University of Pittsburgh, are able to provide consent, have sufficient vision to use a computer, and the ability to understand and communicate in English. A mild to severe TBI is determined by a score between 3 to 15 on the Glasgow Coma Scale. The exclusion criteria from the study includes a score of less than 65 on the functional independence measure motor items, indicating dependence with ADLs, disability from a diagnosis or disorder other than a TBI, and a history of major depressive disorder, mania, hypomania, psychosis, or substance abuse diagnosed by Prime MD or the Mini International Neuropsychiatric Interview within the last 3 months. The outcome measures are broken down into descriptive and primary outcome measures. The previous study collected data on age, race, gender, employment status, and years of education. Information was collected from medical records such as severity of the injury, time since injury, medical burden, and any history of inpatient rehabilitation. The cognitive function was assessed by the completing the 6 of 8 tests in the neuropsychological test battery. The tests utilized in the study include the California Verbal Learning Test 2 Total Trials 1 through 5, the Trial Making Test A time, the Trial Making Test B time, Symbol Digit Modalities Test Total, the FAS and Animal Total Fluency, and the Wisconsin Card Sorting Test Preservative Errors. The Cumulative Illness Rating Scale was used to measure the chronic medical illness burden and assess for comorbidities. The FIM motor items were used to determine motor impairments. The Hamilton Depression Rating Scale and the Apathy Evaluation Scale were administered to assess for affective impairments. And then lastly, the Pittsburgh Sleep Quality Index was administered to determine the sleep quality of the participants. The first outcome measure is the Modified Fatigue Impact Scale. The Modified Fatigue Impact Scale is a modified version of the 45-item Fatigue Impact Scale. The 21-item instrument is reliable and valid. Within the TBI population, the MFIS had high internal consistency with an overall Cronbach alpha measure of 0.97. The MFIS also demonstrated strong convergent validity with the fatigue-related items on the Beck Depression Inventory 2. The MFIS is a self-reported assessment that assesses the effects of fatigue on quality of life and performance of ADLs. The 21 items are split between 3 subscales. The physical subscale contains 9 items, the cognitive subscale contains 10 items, and then the psychosocial subscale has 2 items. The scales used for each item ranges between 0 to 4. A score of 0 indicates no problem, while a score of 4 indicates extreme problem. The scores from each item are totaled to determine a final score, and the maximum score on the assessment is an 84. The higher the score, the greater the fatigue and impact on quality of life and ADLs. The MFIS has been commonly used for individuals with multiple sclerosis and individuals who have experienced a TBI.
The second primary outcome measure for this study is the Fatigue Severity Scale, or FSS. The Fatigue Severity Scale is a commonly used measurement for fatigue severity in those with chronic illnesses. It is a questionnaire that contains 9 items and is rated on a 7-point Likert scale from 1, strongly disagree, to 7, strongly agree. The scores are averaged to find the mean FSS scores, with higher scores indicating greater fatigue severity. The test-retest reliability of the FSS was 0.751, which indicates moderate reliability. The FSS was also precise with a standard error of measurement of 0.7 points, meaning that a change of less than 0.7 could be due to a measurement error. The coefficient of variation showed a change in score of 10.3% or less could be expected over 6 months. The FSS also demonstrated strong construct validity with the MFIS, where R was equal to 0.754. For the procedure, 65 individuals were recruited through local TBI support groups, a TBI research registry, and a university-affiliated medical center. After the inclusion and exclusion criteria were applied, 20 of the 41 eligible participants were randomized into the max intervention group, but 3 participants did not fully complete the max intervention, which resulted in 17 total participants. Baseline data was collected on the participants before beginning the intervention. They then participated in the intervention, and data was collected at conclusion of the intervention, 4 weeks post-intervention, and at 8 weeks post-intervention. The intervention was a maximizing energy intervention that utilized problem-solving therapy to educate those with the TBI on how to manage their fatigue. This was an 8-week course that consisted of 2 one-on-one 30-minute sessions per week delivered live over the internet. In the first week of the intervention, the participants attended 2 introductory sessions where at the end of the first session, they were given a form to track their fatigue. Fatigue-related problems that were interfering with their everyday life activities were identified by the participants. At the next session, the participants prioritized the top 3 fatigue-related problems to target during the intervention. After the first week of introductory sessions were complete, the participants began the 2 30-minute sessions per week. The participants would practice the steps of the intervention with a previously identified problem in the first weekly session. They would then identify a plan on how to implement the solution to their problem and then execute the solution over the next few days. At the second session, the interventionist would assess the problem, the solution that was identified, and the implementation. Once the participants assessed the facilitators and barriers to implementing the solution, if the solution did not work, the interventionist would use the steps of the max intervention to modify the current solution or create a new one. If the participants are satisfied with their solution, then they would move on to the next problem and repeat this process. For the data analysis, descriptive measures were calculated using means, standard deviations, and frequencies as appropriate. A one-way ANOVA for FSS and MFIS scores over 4 time points was conducted to ascertain the effectiveness of the max intervention. A post hoc analysis with paired sample t-test were computed using IBM SPSS statistics.
Now we will be taking a look at the results of the study. I will first be discussing the results of these descriptive statistics. The mean age of the participants in the study was 49 years old with a standard deviation of 15 years. The majority of the participants were white females. The mean education level was 14.6 years with a 2-year standard deviation. Half of the sample did not drive. 20% of the sample was married, and 40% of the sample engaged in work activities while the rest of the sample did not work due to retirement, unemployment, or disability. Participants were around 9 months post-injury during the study, and a majority of the participants had a severe TBI and received inpatient rehabilitation. Overall, the sample exhibited low comorbidity based on the low score on the cumulative illness rating scale. The participants also had low motor impairments as indicated by a mean score between modified independence and independence on the motor items of the FIM. For the cognitive composite score, the sample scored over half a standard deviation below the population mean, indicating mild to moderate cognitive impairment. Participants exhibited some depressive symptoms, but fell below the cutoff score for mild depression severity. Apathy is present within the group based on an average score greater than 34 on the apathy evaluation scale. Participants also reported poor sleep quality with an average score greater than 5 on the Pittsburgh Sleep Quality Index. And for your reference, we have included a table with the results of the descriptive statistics on the following slide. Now we will be taking a look at the results from the primary outcome measures. There was a decrease in MFIS scores from baseline to 8 weeks post-intervention. As seen in the table on the right, the average scores decreased at each time point. The mean FIS score at baseline was 47.06 and decreased to 39.35 immediately after intervention. The mean score continued to decrease 4 weeks post-intervention at 37.47. Lastly, the mean MFIS score continued to decrease to 32.06 8 weeks post-intervention. A one-way ANOVA was completed to determine if there was a statistically significant change in scores. The one-way ANOVA was significant with a p-value of less than 0.001. This indicates a statistically significant difference in score from baseline to 8 weeks post-intervention. Paired sample t-tests were also completed to assess the difference in MFIS scores between the different time points. The results from the paired sample t-test showed scores to be statistically significant from baseline to immediately after the intervention with a p-value of 0.032, baseline to 4 weeks after the intervention with a p-value of 0.008, and baseline to 8 weeks after the intervention with a p-value of less than 0.001. The graph on the right shows the decrease in MFIS scores and the statistically significant differences in scores between each time point.
The mean scores from the FSS decreased from baseline to 8-week follow-up, as you can see in the chart to your right. The mean FSS score at baseline was 5.6013. Then, at intervention conclusion, the mean score was 4.2810. At 4 weeks post-intervention, the scores continued to decrease to 4.2402. And then finally, at 8 weeks post-intervention, the mean was 3.9346. The results from the one-way ANOVA were significant, with p being less than 0.001, showing that the max intervention caused a statistically significant change in FSS scores. A post hoc analysis using paired samples t-tests indicated statistically significant differences between scores from baseline to conclusion of the intervention, where p was equal to 0.003, from baseline to 4-week follow-up, where p was equal to 0.001, and from baseline to 8-week follow-up, where p was also equal to 0.001. One highlight from these results is that the fatigue severity scale scores continue to decrease after both the 4-week and 8-week follow-up, which you can see on the chart to your right.
Now I will be discussing the findings from the study. The purpose of the study was to determine the effectiveness of the max intervention in reducing the impact and severity of fatigue on individuals with a TBI. Currently, there is a lack of effective intervention strategies in reducing fatigue. The max intervention in the study was able to show a reduction in the impact and severity of fatigue. The results also show the max intervention was able to reduce fatigue at intervention completion and 8 weeks post-intervention. This indicates that participants learn and apply what they have learned during the intervention, but they also continue to apply the strategies they learned up to 8 weeks post-intervention. When comparing the decrease in MFIS and FSS scores for each time frame to the minimally clinically important difference, or the MCID, the change in MFIS scores was greater than the MCID from baseline to post-intervention and baseline to 8 weeks post-intervention. And the change from the FSS scores was greater from baseline to post-intervention, baseline to 4 weeks post-intervention, and baseline to 8 weeks post-intervention. There is currently not an MCID determined for TBI, so the MCID for multiple sclerosis was used to determine the clinical importance. The MCID for the MFIS was 4, while the MCID for the FSS is between 0.45 and 0.88. The change in MFIS and FSS scores greater than the MCID increases the credence of the max intervention and shows the clinical importance. Only one other study conducted by Cooper and colleagues has examined the effectiveness of energy conservation education on reducing fatigue in individuals with the TBI. This study had differing results because they were unable to detect statistically significant improvements with fatigue after the 8-week fatigue management intervention. The difference between the two studies is the max intervention incorporates problem-solving therapy with energy conservation education, while Cooper and colleagues study only provided energy conservation education. This shows that energy conservation education needs to be combined with additional problem-solving therapy for the individual to learn and apply the strategies after completing the intervention.
One of the limitations of this study was the small sample size, but another limitation was also that all the participants were Caucasian, so the study lacked a diverse population. For future research, a larger and more diverse sample size should be recruited. Future studies should look at the long-term gains of participants in the max intervention group, including when a booster session is needed. Future studies should also examine other strategies similar to PST to see if they have the same benefit in reducing fatigue over time. The outcomes from this study provided evidence that a max intervention involving PST conducted by occupational therapists decreased the severity and impact of fatigue in those with a TBI. Occupational therapists can use the max intervention with other populations who experience severe fatigue to see if the same benefits arise. While education alone did not show significant differences in fatigue scores, occupational therapists need to pair education interventions with a problem-solving intervention. The results of this study also show that the max intervention can be conducted with individuals with a TBI over the internet, and also shows that this specific max intervention can be delivered over telehealth. In conclusion, the max intervention showed to be helpful in reducing the severity and impact of fatigue in individuals with a TBI. Future studies should look at using this intervention with other populations who experience fatigue after their injury or diagnosis to see if it has the same effect. Occupational therapists should consider using the max intervention to lessen the severity and impact of fatigue in individuals with a traumatic brain injury. And next are our references. And then lastly, we would both like to just say one more thank you to Dr. Reyna for all the time and effort she has put into helping us with our research project. And we look forward to seeing you all in the Collaborate session. Thank you.
Thank you.